Welcome to the 46th Lester Breslow Distinguished Lecture. I'm Ron Brookmeyer, Dean of the UCLA Fielding School of Public Health. What a wonderful occasion this is, the celebration of the legacy of Dr. Lester Breslow, extraordinary public health leader, eminent professor and researcher, and the second dean of our School of Public Health. Throughout Dr. Lester Breslow's more than 70-year career, his vision advanced public health. He showed us the importance of prevention. He answered the question, what is a healthy lifestyle? Dr. Breslow's groundbreaking work showed that people with healthy habits, those who exercise, get enough sleep, eat well, abstain from smoking, can live longer. His work provided key data linking smoking and lung cancer, arguably one of the greatest achievements of public health. Dr. Breslow held many important positions throughout his extraordinary career, including president of the American Public Health Association and director of the California Public Health Department. And in 1972, he joined our school as dean, a position he held until 1980. Dr. Breslow's legacy endures at the Fielding School and in public health. And I'm so pleased that Deborah Breslow is with us today. Deborah was very much a partner in Lester's public health career and accomplishments, and we are all grateful for her dedication and commitment to our school and to public health. Thank you, Deborah. Dr. Breslow played an important role in mentoring the next generation of public health leaders. Last year, we held the Breslow Impact Fellowship competition. We challenged our students to creatively share their personal stories about public health impact. We received numerous submissions in a variety of media, essays, artwork, photography, poems, and videos. We were unable to recognize our fellowship recipients last year because of the pandemic. So I'm delighted to acknowledge our recipients now. First, I'm honored to recognize two student recipients who each received $1,000 fellowships. Anna Peare for her essay titled At the Intersection of Disability Rights and Public Health. Taylor Rogers for her video submission addressing health equity. Congratulations, Anna and Taylor. And now, I would like to introduce the winner of the Lester Breslow Impact Fellowship who received a $5,000 award. Kamila Tan, MPH class of 2020, for her poem about her journey with anorexia nervosa. Kamila's work helps destigmatize eating disorders and other mental illnesses and offers hope and help to those who are struggling today and their families. I am delighted that Kamila will now share her story and her poem.
Impact. I won't sugarcoat it. My past has been one of pain. I've been broken, lost, weak, depleted, and near death. I almost lost my life to a demon that lived inside my own mind and manifested itself in my actions. It convinced me that my own body was my enemy. This is how twisted mental illness can be. Over time, as I've begun to heal, I've realized and learned that trauma repeats itself. And by never confronting or healing the damage that had been done to me by others, I was perpetuating that cycle of trauma by damaging myself. I didn't understand that I deserved to be treated better, with respect, with love, with compassion, not only by others, but most importantly, by myself. An eating disorder is an insidious illness. Misunderstood and stigmatized by many, society chooses to stay silent on a topic that kills, that takes lives, that ruins relationships, and reduces personalities to harmful cycles of controlling food and exercise. Not for vanity, not for attention, not for selfishness, but ultimately as a way of coping with a soul's enemy. Fear, depression, exclusion. Because control, it gives you something to focus on other than the pain. And stigma silences conversations that lead to community, understanding, and ultimately healing. And healing quells fear. It's time to break the stigma, break down walls and destroy barriers, and listen to one another. Because it's in the times when my heart was beating less than 40 beats per minute during the day, and I was so sick and so lost, I wished someone would say there's a way out. The lights are brighter on the other side, and Kamila, you're going to be okay. I promise, you're going to be okay. In that hospital bed, I lay. Sometimes, the only thing I knew how to do was pray. A couple others that were there with me, they died. Yet here I stay. They didn't deserve to die from their eating disorders. I'm lucky I lived. I'm lucky I'm here today. So now I have a message I want to relay. Because I was given a second chance. To live or to die, I was given a choice. And I chose to fight against my eating disorder, to fight for my life, and now I have a story and a voice. During this time that I've been fighting through my own mental distress, I've noticed so many gaps that need to be addressed between knowledge and action, between words and traction, between discussion and policy, between listening and understanding, between silence and judgment. I'm sick of the stigma that leads to corruption of minds and of hearts that end up in destruction. It might have been prevented with a little instruction on topics uncomfortable, but necessary to approach for construction of new avenues for change, and systems that foster connection instead of blame, and safe spaces that offer support so that those who are in pain don't resort to destructive behaviors embedded in shame. And I will use my name to advocate for anyone else who feels or has felt or is going through or went through something similar or something the same. Recovery from my eating disorder has been about rediscovering and owning my own truth, about healing from trauma far past in my youth, about relearning how to smile and cry and laugh and scream and feel, and no longer pushing down the pain I didn't want to believe was real. But you, dear listener, how would you know that? if you weren't told? How would you understand if I wasn't so bold as to share my story as it still unfolds? You wouldn't know. And you wouldn't understand, and society might tell you that eating disorders are vanity or insanity or a fallacy, but in reality, they're real. And so many others besides myself need to heal. You asked me, dear listener, how I plan to make an impact. My most honest answer is, I don't know right now. I'm not exactly sure how. But I do know that powerful stories can sweep a nation, and mine could be paired with evidence-based education. And I'm already known for persistence and dedication to my cause to give affirmation to anyone else who might be lost in the desiccation of an eating disorder. Darling, you're not alone. And I promise there is liberation waiting for you. Choose it. I know that lives can change with openness, willingness, and vulnerability to share what some others would pretend is invisible and isn't there. I think my desire to care has already impacted. But don't worry, dear listener, I won't stop there, because I know there's more work to be done here. There are perspectives that need changing, and entire systems that need rearranging, and discussions that need exchanging, and individuals who need to be met with compassion, love, and care instead of estranging. Wouldn't that be just amazing? There's so much more work to be done, and of all the voices and stories in this world, mine is just one. But in fact, my impact has only just begun. I wrote this piece to paint a verbal picture of what it's like to have an eating disorder. Eating disorders are incredibly complex, and mine served a purpose to cope with anxiety, depression, and trauma. For years, I found it almost impossible to speak about my experiences with an eating disorder because of the stigma that surrounds eating disorders, which is so strong. It's a vicious cycle. But I found that cycle can be broken when those who are suffering speak up and share their stories, and when communities are educated and provide safe spaces for them to heal. One of the biggest breakthroughs in my process of healing was the moment when I finally decided to open up and expose my eating disorder. And the support system that surfaced was beyond anything that I could have imagined. Community. So as individuals, let's show up authentically. And as communities, let's become as aware and as informed as possible so that we can provide support to one another. Thank you to the communities of support who have enabled me to heal. Now I will pass it forward. And thank you to the Breslow Fellowship for providing me this opportunity to create an impact.
Thank you so much, Kamila, for your willingness to share your journey with us, for your inspiration, for increasing awareness of eating disorders, and for all you do to have a positive impact on the health and well-being of those afflicted, those at risk, and the families and friends that support them. Congratulations on your award. It is now my great pleasure to introduce Dr. Harvey V Feinberg, who will deliver the 46th Lester Breslow Distinguished Lecture. Dr. Feinberg serves as president of the Gordon and Betty Moore Foundation, which fosters scientific discovery, environmental conservation, patient care improvements, and preservation of the San Francisco Bay Area. Dr. Feinberg previously served as president of the National Academy of Medicine, provost of Harvard University, and the dean of the Harvard Chan School of Public Health. He has made important contributions in the fields of health policy and medical decision-making, especially in global health, assessment of medical technology, evaluation and use of vaccines, and dissemination of medical innovations. Dr. Feinberg's lecture, Truth and Trust in Public Health, is especially timely in light of all that we have experienced since the beginning of the COVID-19 pandemic. Now, following the lecture, we'll have a Q&A with Dr. Feinberg, and you can please submit questions that you have for him by clicking on the Q&A button near the bottom of your screen. I'm honored and thrilled to have Dr. Feinberg with us today, and without further ado, Dr. Harvey V. Feinberg.
Well, Dean Brookmeyer, thank you so very, very much for that kind, generous introduction. I can't tell you what a pleasure it is for me to be with you, even in this virtual way, at the UCLA Fielding School of Public Health to deliver the 46th Lester Breslow Lecture. For all of us of a certain age, Lester Breslow was a friend, a mentor, a guide, really a paragon of what a public health professional could mean. He was the one really who set standards for dealing with chronic disease and prevention of disease in that great transition for public health, expanding its scope of attention from the acute infectious diseases to embrace the chronic diseases as well. I want also to just take a moment to extend my congratulations also to Anna and to Taylor and to Kamila for their awards. It was wonderful to learn about those, and especially Kamila, to hear your moving story. It's actually not unrelated to the topic that I want to talk about, which is the idea of truth and trust in public health. I want to begin by identifying a number of background premises about the role of science and public health. Yes, it's true that science is the basis of truth-telling in public health. But at the same time, if science is the rock that we stand upon, it can be a slippery and uneven surface. Yes, everyone wants certainty and easy decisions, but public health is replete with uncertainty and difficult decisions. Yes, the facts should speak for themselves, but in fact, the facts seldom do. All messages are framed by the messenger, by the content, and by the context in which they are delivered. We're taught in public health to respect evidence. This was Lester Breslow's absolute point of emphasis. We know that the plural of anecdote is not evidence. At the same time, evidence and facts are not what necessarily moves people. People crave stories. They want to know what happened to an individual. And those stories are memorable and convincing. Imagine if Kamila had taken her time just to recite facts about eating disorders. I think none of us would have been so gripped, engaged, and moved by what she was saying. Yes, it's true that the internet amplifies lies and misunderstanding. At the same time, we have to recognize the internet is not our only problem. Today, I want to cover briefly 3 different underlying complexities that affect health communication being truthful and persuasive in public health. The first has to do with recognizing the vagaries of science itself. Second, I want to touch upon decisions, personal or policy, that are uncertain and difficult. And finally, I want to spend a little bit of time talking about the importance and influence of framing and bias. On science, let me begin with a little excerpt from a film of Woody Allen that was made in 1973, but set 200 years into the future. What happens is that the lead character, Woody Allen, wakes up 200 years in the future, and he's confronted by two scientists. Dr. Mellick, one of them, says, "This morning for breakfast, he," referring to Woody Allen, "requested something called wheat germ, organic honey, and tiger's milk." Dr. Aragon says, "Oh yeah, those are the charmed substances some years ago were thought to contain life-preserving properties." Dr. Mellick says, "You mean there was no deep fat, no steak or cream pies or hot fudge?" Dr. Aragon replies, "Those were thought to be unhealthy, precisely the opposite of what we now know to be true." Dr. Mellick says, "Incredible." It's kind of funny. It was very funny in 1973, but I can tell you in 1973, a lot of people believed that butter was unhealthy and margarine was the healthy alternative, precisely the opposite of what we now know to be true about margarine and trans fats. I can remember the time not so long ago that adult men were advised to take a daily baby aspirin to reduce the risk of heart disease. And then later, well, don't bother, the evidence isn't really holding up. Science evolves. And with that evolution comes a sense for those of us aware of that evolution of great humility about science. Now, I want to move to the idea of what makes decision-making or policy-making difficult. And let's start with an easy choice. Suppose that you're in a room and it has one door. And I'm going to tell you, if you walk through that door, you're going to die right then and there. But if you remain in this room, you will live. Now, suppose for a moment you suspend disbelief and you accept the premise of the question and you believe it. What would you do? Well, I think the answer is pretty simple. You'd stay put. Why is that easy? Well, there are only two choices, stay, go. There's no uncertainty. You're going to definitely die if you walk out the door. There's an immediate outcome, and what's valued is something you care a lot about. It's your life. The decision is entirely up to you. And the best choice is really obvious if you cherish life and you seek to avert immediate death. So this is an easy choice. It's in a decision space, you could put it right at the origin. It's a single attribute, life, death. It's certain, no uncertainty, and it's going to happen right now. But the real world isn't made up of these types of situations. In the real world, there are multiple valued attributes. Typically in health, it's going to be benefits and risks and costs. There are also always uncertainties attendant to what will follow if you take certain actions or you fail to take certain actions, or if nature takes certain course or some other course. And finally, things don't happen right away. They may happen over time, sometime into the future. So if we're trying to cope with this space of multiple attributes, lots of uncertainty, delays until things will actually happen, in the real world, we're dealing with decisions somewhere way out in this three-dimensional space. Multi-attribute, uncertain, going to happen in the future. Now, I can tell you, and if you've been paying attention for the last 5 minutes, I can spare you 2 semesters of courses on decision science, because basically all of decision science is entirely about taking real-world situations comprised of complex multi-attribute options with uncertainty and delays and converting them analytically to a decisionally equivalent choice that is essentially reduced back to that simple single attribute equivalence of certainty and equivalence of now. How does it do that? Well, it applies when decisions have to be made, when events are uncertain, and you have multiple discrete, differently valued outcomes. So in the real world where there's multiple outcomes, decision analysis moves you to the simpler choice by using utility analysis to get you to the best and worst outcomes, and place all the intermediate ones on that utility scale. It takes multiple uncertainties in the real world and it moves them with probability over to an overall expectation. It takes delays in time and it uses discounting to create an equivalent present value. And it basically uses models, decision trees, or other more complicated models to reduce a complex situation to a clearer situation. So in the real world, you deal with these multi-attribute, complex, time-delayed, and very uncertain situations. And they add a challenge to trying to make a decision, but also to communicate a decision to others. Now, I want to also touch upon the point of framing. And the framing of a choice is a very powerful influence on the perception of which of the options may be preferable. I want to take us back to a classic experiment that was done literally 4 decades ago. And it was based on a premise that the US imagined is preparing for the outbreak of an unusual Asian disease. This is a direct quote from 4 decades ago. It's expected to kill 600 people. 2 alternative programs to combat the disease have been proposed. Assume the exact scientific estimate of the consequences are as follows. Follow program A, 200 people will be saved. If you adopt program B, there's a 1/3 probability 600 will be saved and a 2/3 probability no people will be saved. I can't see your faces, but I hope you're clear on the choices. And I'd like you to think about this. Would you prefer, under these circumstances, program A to save 200 people or program B, the lottery, with a 1/3 probability to save 600 and a 2/3 probability that no people will be saved? Have you got that? Everybody got it? Write down your answer. Just a little note beside you. Okay. Now let's consider a different situation. In the real experiment, these two are not shown to the same groups, but the real experiment begins with exactly the same premise, the same unusual Asian disease, the same expectation to kill 600, 2 alternative programs. Assuming the exact estimate is as follows. Program C, if you adopt it, 400 people will die. If program D is adopted, there is a 1/3 probability nobody will die and a 2/3 probability 600 people will die. 400 will die for sure with C, but if you adopt D, you have a 1/3 chance nobody dies and a 2/3 chance 600 die. Now think about this problem. Set the other out of your mind. Which one do you favor here, C or D? I can tell you without looking at what you've actually written, most people, given these 2 different scenarios, the first will favor A and the second will favor D. Why is that? Well, first let's compare the 2. Perhaps it should be obvious that not only was the expected value of the lottery the same as the first certain option, but actually the 2 lotteries are identical and the 2 certain options were identical. A, where 200 is saved, means 400 die. C, where 400 die, means 200 are saved. Those are identical. And B, where there was a 1/3 probability of saving 600, nobody dies, 2/3 that no one is saved, 600 die, that's exactly the same as D. 1/3 probability no one dies, that is 600 saved. 2/3 probability 600 die, that is no one is saved. So analytically, numerically, A is identical to C and B is equivalent to D. What is the difference? The difference is that A and B are framed as gains, while C and D are framed as losses. And it turns out, on average, more people, when thinking of gains, tend to be risk averse. They'll take the sure thing. They prefer A over B. But if you start thinking in terms of losses, you tend to be risk seeking. You're more willing to gamble. Now, I've thought about these examples personally, and I've talked with others about them scores of times. And I still, frankly, have a preference for A if I'm only thinking about A and B, and a preference for D if I'm only thinking about C and D. It's a little bit to me like this classic perception question, which horizontal line is longer, the one on the top or the one on the bottom? And of course, the answer is they're identical in length. They're just framed differently. And I feel the same way about these effects of framing as a gain, you're risk averse, framing as a loss, you're willing to take that risk to avoid that loss. There's another refinement on these studies, which is directly relevant to us in public health. It turns out if you present efficacy data as a relative risk reduction, more people will accept the implication than when you present the data as an absolute risk difference. So, for example, if you say this drug can reduce your risk of malaria by 50%, that's more persuasive than if you say this drug can reduce your risk from 20 per thousand to 10 per thousand. Now, I want to move to another element of this immunization question, a hypothetical question. Let's suppose there's an emerging respiratory virus. It's afflicting other countries and moving steadily toward your country. Everywhere it is struck, 30% of the people have died from it. There's a new vaccine which is perfectly protective against that strain, but the vaccine carries a 10% mortality from side effects. You're the Commissioner of Health. Should you deploy this vaccine? Well, you might want to think about it. I can't see your hands, but how many of you would use the vaccine knowing that it has a 10% mortality? I think Lester probably would have, but it's arguable. Oh, what if I said, oh, wait a minute, I made a little mistake. I actually, if the disease comes, 10% of the people die. If you use the vaccine, 30% die. Well, if I said that, it's a no-brainer. You never use a vaccine that's going to kill more people than the disease. So why was it a question at least worth thinking about in the first instance, but it's a no-brainer when you reverse it? Part of the reason is that when we're thinking about prevention, we tend to be biased against errors of commission. We don't want to be responsible for harming a healthy person. By contrast, I would argue many clinicians treating a very ill patient tend to be biased in favor of commission and against errors of omission. They'll do more to overcome the illness. And in public health, when you've got a healthy person, you don't want to feel that weight of responsibility for potentially harming them. So that's one of the common biases in public health, is overweight of errors of commission. Let me mention a couple of others. You tend to overweight your own data. How many times have epidemiologists poo-pooed others' data in favor of their own because they trust their own data? And I would just say it is easier to see a pebble in your neighbor's lawn than a boulder sitting on your own rooftop. People are not objective about their own data against others. Another common bias is overconfidence, in which conviction tends to outpace evidence. So, for example, real epidemics occur only occasionally. The data over time are sparse, but you've got a lot of time to think about it, and you may reach more firm conclusions than the evidence actually warrants. And then another problem is to overextend your own expertise. This is why Nobel Prize winners come to think they are able to comment intelligently on any subject under the sun, and why, for example, a neuroradiologist can fancy himself as advisor to the president on a public health response to a COVID crisis. Now, I want to just conclude with a few key points. First, science is a dynamic and evolving web of knowledge. Second, as public health professionals, we have to learn to live with probability, uncertainty, and making difficult decisions. Informing our communications, we have to recognize framing effects and biases. You can't ignore framing, but how do you use it? How do you give genuinely balanced guidance, knowing the effects of framing and trying your best to guard against your own biases? But let's conclude on a positive note. The hallmarks of sound public health communication. First, it has to be timely. It has to be correct, meaning it has to be accurate and balanced. It has to be clear so that it's understandable. It has to be consistent in order to maintain public confidence and trust. Was it very good that the CDC, for example, in August told people, oh, if you're exposed, you don't need a test, but then in September reversed itself? Not good for public health communication. It has to be targeted to the audience. You have to know the values, interests, and resonance of that audience, and you have to be willing to repeat. And finally, I'll relate back to a point that Kamila made in passing, that the strongest communication will combine the personal stories to reach the emotional and interest of your audience with the factual base of what public health and science teach are the right ways to approach a problem. If you can master that combination, if you can take account of uncertainty, if you can acknowledge and use the bias and framing effects, and if you can adopt these hallmarks of sound public health communication, you can be truthful and you can be powerful as a public health communicator. Thank you very much.
Dr. Feinberg, thank you so much for that engaging lecture. And now we're going to have a Q&A. So I've got the first question for you. In COVID-19, there have been openings and closings as we've addressed the pandemic. Parks sometimes open, beaches closed, schools open, closed, dining open, closed. And the science behind it is not always completely clear. How do we explain all this to the public, this confusion, and at the same time increase the trust in public health and the science of public health?
It's a dilemma because, as Einstein said, make everything as simple as possible and no simpler. And sometimes the evidence is genuinely ambiguous. One of the temptations is to project what we think is the right thing for people to do, and then to overstate the evidence or the confidence in the existing evidence that supports a given course of action. I think that's a very slippery slope to get caught upon. In general, as Mark Twain said, when in doubt, tell the truth, which is to say, do your best to express the evidence in a way that is clear, that is faithful to the evidence, that does not do injustice to the evidence. Do not overcomplicate. Do not try to give all the nuances. Do not stress all the uncertainties, but do not go beyond the facts and evidence that take you to a certain point. And explain why then the basis for action is indicated. And here is where I think, frankly, you might be willing to adopt some of the framing lessons. If you, as a public health professional, believe it really is important for people to take steps like take your vaccine or wear your mask, what framing would teach us is if you want them to do something that they might perceive as risky, messaging should stress avoiding the bad effects that would follow if you fail to do this more than the benefits of doing it. So that would mean, for example, if you want people to wear masks, you talk about the dangers of communicating this disease to others and to even your own family without wearing masks and so forth. So it's not an easy answer, Ron, and it's not a simple answer, but you have to do your best to balance the scientific fact and to convey it with integrity and honesty, but also in a way that reinforces the best choice on the part of your audience, the public.
Great. And there's a related question. Given all these points that you've covered, what advice do you have to convince people hesitant to take the COVID vaccine? How do we approach vaccine hesitancy? How do we communicate what vaccines can do?
I actually think that only a part of it is describing the benefits of vaccination. You can talk till you're blue in the face about 72% or 94.5% protection and explain what that means. It doesn't mean usually what most people just think it means. But you also need to couple that kind of messaging of the facts with the right messengers and the right influencers. So for example, for me, I would rather see our celebrities, our sports figures, our musical figures, our actors, people that others know and trust, our community leaders, our religious leaders of faith, our leaders of the civic organizations. I would rather see them modeling the behaviors of getting immunized and demonstrating their own commitment to doing their part to protect both themselves and the community as a way of reinforcing and overcoming hesitancy. I would have organization of focus groups and discussion groups with those who've gotten immunized, who are just like me, but they're my neighbors, they're my colleagues, they're my friends, they're people I know and trust, and they got immunized. And they're going to tell me that the biggest and most pervasive side effect from immunization is an instant feeling of euphoria. And so you learn this from your friends and you absorb the idea of what is the right thing to do because it becomes the social norm as well as the factually, scientifically correct thing to do. So here again, we're actually getting back to Kamila's point, which is couple the personal invested story with the knowledge and factual base of the problem you're trying to communicate about.
Great, thank you. Next question is, many people cannot assess the evidence and have to rely on and trust the messenger. Expertise as a source of trust seems to have declined and political affinity has grown. How should public health professionals respond to that?
It's another really challenging point. The data that I have seen about scientists and health professionals is actually not discouraging. That is to say, the public trust in health professionals, public trust in scientists generally is pretty high. I mean, there's low trust in politicians, there's low trust in journalists. There are professions that are very low on that scale, but we start in public health and the health professions actually at a pretty high level. Among the highest, by the way, are nurses. Nurses are very, very highly trusted because people understand nurses have their interests at heart. So we start already not with quite the deficit at the premise of the question I would submit. But having said that, the question is extraordinarily important because people are now inundated with multiple sources and drawn into channels of distracted sources through the internet and other kinds of social media that keep them from the typical historical exposure mainly to experts. And that means that those of us who care about reaching the public, influencing action, helping people, as Lester Breslow devoted his life to staying healthy. If that's what we want to do, it's incumbent on us to understand and become better masters of those media. to understand the way networks and influencers work, and to use them for good, just in the same way they can be used for perverse, unhealthy purposes. So it's not an easy assignment, and there won't be a lot of people who are gifted both in the domains of communication and media, as well as in science and public health. But those individuals are extraordinarily precious and valuable to the health of our public. And using that combination of expertise is our best hope, I think, of responding to the question. Great.
Thank you. Next question. Public health communicators often have their messages translated by the media. And in the case of COVID-19, the media have a tendency to stoke fear, which does not necessarily result in positive decisions. Can you address the use of fear in communicating public health messages?
Well, fear is, of course, an emotional reaction. And we're trained in science and public health and health in general to use rational intellect and not let emotion take you away. At the same time, what affects people and their belief in what they want to do is emotion. Can you counter emotion with calm? It's the best antidote. You don't counter fear with screaming at people that they're just wrong. You counter it by calm repetition, clear, consistent messaging about what the facts are. Now, let's also be clear. Some parts of a public health emergency are genuinely frightening. The fears are not necessarily misplaced. And so you then want to channel that fear into effective action. Where fear is counter to public health is where it is immobilizing and preventing people from taking the actions that they can take. So if you can counter the fear by indicating to people, here are the steps you can take personally for yourself. Here are the steps you can take for your family. Here are the steps you can expect your public health leaders to be taking in your behalf. Then you give people a sense of efficacy, a sense of control, a sense of the power to gain some modicum of confidence, of comfort, of overcoming that fear. And that's an important part of communicating for health as well.
Great, thank you. Next question. What do you think of how CDC handled things? And do you think the CDC can regain the trust of the public after all that has happened this past year?
First, I would say absolutely it can regain the trust of the public. It won't happen instantly. It will take time. But the CDC is filled with extraordinary, capable, dedicated health professionals, and that will come through over time. Obviously, they went through a period, as every health agency, every agency of government, in which a heavy political overlay was really distorting of the both traditions and expectations of what sound science in government can accomplish. So when you had periods where MMWR was being edited by political figures, or announcements by the CDC were being delayed, that was a political overlay. At the same time, it is fair to say there were some self-inflicted harms. CDC did not distinguish itself in the early days of the pandemic in the development of diagnostic tests. That was really a very sorry episode in the CDC. I made reference briefly to the flip-flop in whether you get testing when you've been exposed. So that's not a good thing. I am very confident in the skills of Dr. Walensky, who's our current CDC director. I feel that she has a gift for clarity of communication and deep knowledge about infectious diseases and the role of the public sector in helping to contain infection. So I'm hopeful that we're going to be on a very positive path for the CDC going forward.
Great, thank you. Next question is, how, in developing public health messaging, how do you tailor it to fit diverse populations and cultures, and craft them to be most effective?
First, you have to recognize the importance of doing that, because if you don't concentrate on the cultural starting point of your audience, you are losing the opportunity to reach that audience. So the first step is recognizing the importance of culturally relevant, meaningful communication. That's partly language, it's partly forms of expression, it's partly the media, and it has a lot to do with the messenger. So understanding the trusted sources, understanding the channels that are utilized, understanding the role of informal as well as formal communication, networks as well as traditional channels. These are all part of shaping your messaging and your outreach to fit the audience. And that is a very fundamental principle for effective public health communication. Start with your audience. Shape your message to be culturally and individually relevant to that audience.
Great, thank you. Next question. What advice do you have for recent Master of Public Health graduates as they navigate a myriad of public health crises with COVID and beyond?
I cannot think of a more exciting time to be embarking on a public health career than today. This is a moment when not just the US public, but the entire world is riveted by this crisis and emergency, and how important it is today to have individuals trained at schools like the UCLA Fielding School of Public Health, who can bring their expertise, their dedication to bear on the solution of health problems. And they are myriad. We can find ways to make a difference for public health in traditional public health, in health institutions of all kinds, in industry of all kinds, in the private as well as the public sector, in the nonprofit as well as the for-profit sector. Everywhere you look, there is an opportunity and need for trained public health professionals. So for me, I cannot imagine a better time to be embarking on a public health career. And I congratulate all those at the school who are on the verge of launching their own careers, and look forward, as I know you do, Ron, to seeing what they will accomplish and how much good they will do in the next years and decades ahead.
Great. There's another question here again about the COVID vaccine and its novelty and how we address questions of public trust when you have a new vaccine compared to other vaccines which have had years and years of research. How do we address that novelty in public health and innovation?
Yeah, first we should be acknowledging that these are novel vaccines. And when you're testing a vaccine in tens of thousands of people, and you may do that test over 4 months, let's say, a side effect that is going to express itself in one in hundreds of thousands or millions of people, a side effect that could be very, very severe but rare, may not even be detected. So you would put into place the follow-up, which the CDC has about the follow-up of the vaccines. And the novelty of these vaccines is a reason that they were able to be completed in the space of a year. If we didn't have these novel technologies with the messenger RNAs and the viral carriers for the vaccines, we'd still be growing, virus in eggs, and we wouldn't be anywhere near where we are. So that novelty does come with risk, comes with uncertainty, but weigh that against the tangible benefit and the growing confidence in the benefits as we look at the experience in actual immunized populations. And finally, keep in mind, COVID could evolve in something like an influenza-like model where different strains that become prevalent in different seasons may require re-immunization over time to regain protection against the then most prevalent strains. That all remains in the future. So the short answer, Ron, honest about the uncertainties, but confident that the benefits we're experiencing outweigh those intangible and unknown uncertainties.
Great. We have, thank you. We have time for one more question. And so the last question is what can schools of public health do better? How can we improve education on public health communication and public health decision-making?
That is a long answer to a very short question, Ron. But I would say very briefly that schools need to help students have their feet on the ground and their heads in the clouds. And what I mean by that is they need to instill a combination of a vision of what is possible and what it takes to get there, while also grounding in very practical, real-world actions that can promote and protect the public's health. We need our schools of public health to be the centers of foment, of innovation, of research and learning about new models and new ways of achieving health, and at the same time of making best use of available resources, skills, and capabilities to protect health with the tools we now have. That's a very short answer, but there's a lot embedded in that we would have to tease out and discuss over a long time. I hope someday before too long in person, Ron.
Absolutely. I look forward to that. That was terrific. Thank you so much. Let me close by thanking Dr. Feinberg for sharing his thoughtful perspective on these critically important topics, and also to Kamila Tan for sharing her powerful poem. And I want to thank all of you in attendance today for joining us and for helping to carry on the extraordinary legacy of Dr. Lester Breslow. Have a wonderful evening.